Okay, we're ready to get started. Is this on? Can you hear me? Okay. Ready to get started with our next really interesting discussion and presentation. Age-related eye problems, affects every single person in this room. I guarantee it. We're joined today by Justin Kanoff, Dr. Justin Kanoff. He's a fellowship-trained specialist in retinal disease and surgery and a board-certified ophthalmologist. He completed his residency and fellowship at Harvard Medical School. He spent an additional year there to serve as chief resident and director of ocular trauma service. Dr. Kanoff specializes in surgical medical treatment of vitreoretinal disorders such as diabetic retinopathy, macular degeneration, and other vascular diseases, because these words are too tough for me to say. And then Dr. Joel Meyers, not the meteorologist, is a fellowship-trained specialist in oculoplastic surgery and board-certified ophthalmologist. Additionally, he served full-time faculty and clinical lecturer at the University of Arizona Health Sciences Center. Dr. Meyers specializes in cataract surgery, cosmetic, reconstructive eye plastic surgery, and tear duct obstruction repair. So please join me in welcoming Dr. Justin Kanoff and Dr. Joel Meyers.
Thanks for that introduction. Thanks for having us. I appreciate you taking some time on Saturday to spend some time with us. Hopefully this will be informative and interactive, and if you guys have questions or please go, feel free to ask questions. Try to make it interactive and tailor it to your specific interests. So just what we're going to do is we're going to just do a brief introduction, talk a little bit about how the eye works, talk about what macular degeneration is and how we treat macular degeneration, and then we can take questions at the end, or we can also take some questions as we go if some topics come up or we need a little more information. So I already got a nice introduction. So my name is Dr. Kanoff, eye specialist at the Eye Care Center of Northern Colorado. So we're a multi-specialty eye care practice serving the Boulder, Longmont, Lafayette, sort of Northern Colorado region. And we have nine doctors and 3 optometrists, and we sort of cover the whole range of different eye problems and eye disease and able to treat all the needs. Our offices are in Longmont, Boulder, and Lafayette, and then that's how to contact us if any questions or needs arise. We also have our surgery center in Longmont, and we're really lucky to have that state-of-the-art facility. All we do there is eye surgery, and so the nurses and the equipment and everything is specialized just for eye care, and it works out really well for patients in order to get the best outcomes for their surgery. Okay, so a little bit about how the eye works, and then we'll get into the treatment and what macular degeneration is. So this is a side view of the eye, and basically the eye is set up to collect light from the outside world, and then it's all set to focus that light in the back part of the eye. And then once that light's focused, that information is then transmitted to the brain, and then that's how we see and form images. So light enters the eye through the front part, the cornea, and the pupil, and the lens, which is in the front part here. And then light's focused onto the retina in the back part of the eye. And I like to think of the eye sort of like a camera analogy. I think that makes it really sort of simple for understanding what's happening in the eye. So the front window you're looking through, that's the cornea. And then the middle part of the eye is where the lens is. And the lens, just like in a camera, focuses light and tries to collect that light. And then in the back part of the eye is where the retina lives. And the retina is like the film in the camera. So that's the actual part of the eye where the image is forming. And then the last big component is the optic nerve, and that's like the cable that connects the camera to the computer. And so all that information from the eye is sent through the optic nerve, and then it goes into the brain, and then that's how we all form images and are able to see. So we're gonna focus more in the back part of the eye, which is that film part of the camera, the retina, because that's where macular degeneration happens. And this is just a photo of a healthy back part of the eye. And just to orient everybody, so this yellow spot here in this, off center, that's the optic nerve. So that's that cable that connects the eye to the brain. And then all of the red lines coming out of it are the blood vessels, the arteries and the veins. And then the center part is that little sort of different coloration right in the center. And that's what we call the fovea and the macula, where macular degeneration happens. And this center part is where all of your really high quality 20/20 vision comes from. And that's the part of the eye where it starts having trouble with macular degeneration. And that's where a lot of our treatments and prevention is focused on. So macular degeneration is a leading cause of severe vision loss in people over the age of 65 in this country and really around the world. And I think there's a little bit of sometimes a misconception that patients or folks feel like, well, as you get older, it's just natural for the eye to lose vision and just for your vision to get worse. And that's not entirely true. Really, macular degeneration and vision loss is a disease, just like heart disease or other things. And we want to focus on prevention and treatment to keep the vision healthy and to keep that natural good vision. So macular degeneration, it's almost always going to be in both eyes, but for most people, one eye is going to be significantly worse than the other. So a lot of times people will feel like they really have it in one eye, but it's usually a disease that affects both eyes. We can see it on both sides. So it's really, and these numbers are all from this country, and it's a really common problem in this country. People over the age of 65, about 2.5% of people have macular degeneration, and then as we get over the age of 75, upwards of 10 or 11% of people in the country have some form of macular degeneration. So it's very common, and so it's a big area of research and to try to prevent the disease process from affecting people's eyes. And it's really hard to describe vision to folks and sort of say, well, what does macular degeneration look like? So there's some cartoons that try to sort of relate what macular degeneration is like. So on the left here, if this is normal vision, macular degeneration is a disease that's going to affect the center part of your vision. There's different diseases in the eye like glaucoma or other things that can affect your peripheral vision, but macular degeneration affects that central part of your vision, which is so critical for reading and driving and watching TV and things like that. So a lot of patients, when it gets advanced, will describe that there's sort of a spot missing in the center part of their vision. So what are the risk factors for macular degeneration? So there's some very well-established risk factors, and then there's some other risk factors that in some studies, maybe it's a risk for macular degeneration. Some studies are a little less conclusive. So obviously, we definitely know from the name, age-related macular degeneration. It's a disease that affects patients who are older. Family history is a very big component of macular degeneration. And as we learn more about the genetics of macular degeneration, probably upwards of 40% of the risk comes from genetics and family history. Cigarette smoking, just like a lot of things in the body, smoking is a big risk factor for macular degeneration getting worse. And then we also think sort of a low dietary intake of antioxidants and certain vitamins. So if you look at sort of the top three risk factors, age, family history, and cigarette smoking, only one of those we can change. And so really that's yet another reason for patients not to smoke, because that's the biggest risk factor of macular degeneration that we can actually affect and change, because you can't change your age and you can't change your family history. Other things that sort of come up in some studies, there's maybe a suggestion that it's more common in women, more common in patients with cardiovascular disease, different systemic conditions like obesity or high blood pressure. But it's really hard, especially with the cardiovascular disease and some of these other diseases. Is it the fact that patients have high cholesterol, or is there something about patients who have high cholesterol and macular degeneration? So is it really one causing the other, or is it just sort of a correlation that goes? And that's why it's a little unclear. So one thing that's definitely not a risk factor, and I think this is a common misperception that patients have, and I think it sort of makes patients nervous about getting cataract surgery, is there was a thought maybe about 10 years ago that cataract surgery caused macular degeneration to get worse. And there's been a lot of research and a lot of studies, and it's very conclusive that cataract surgery does not cause macular degeneration to get worse. And actually, on the contrary, patients with macular degeneration are some of the folks who can benefit most from cataract surgery. Because if you think of it, that the eye is already having a little bit of trouble seeing, a little bit of trouble processing that light, and then you put something in there like a hazy cataract, it makes it even harder for the retina to work. So actually, it's the opposite. Getting rid of that cataract is actually more helpful for patients with macular degeneration. And so one of the real common things that patients sort of note is they have a difficulty recognizing faces, difficulty reading. It's right in that center part, unfortunately, is where the trouble is. So patients can have distortion in vision. So how are we going to diagnose macular degeneration? So there's a lot of testing in the clinic and a lot of different photos that we take in order to allow us to diagnose this. So this is a very similar picture to what we had up on the screen at the very beginning. And the main difference that you can see is there's all of these yellow spots in the back of the eye, and that's one of the hallmarks of macular degeneration, and we call those drusen. And they're little yellow deposits that form underneath the retina, and then are part of the process that then causes dysfunction and trouble for the retina as it progresses over time. And these are just some of the other tests that we do. So this is just a color picture so we can sort of see what the back of the eye looks like. This is a picture specifically looking at the blood vessels inside the eye. So all of these white lines coming out, these are the blood vessels in the back, and we inject a special dye inside somebody's arm, and then we take pictures as it flows through the eye, and that helps us figure out, is there a problem with the blood vessels in the back of the eye? And then this is what we call an OCT, which is sort of an X-ray of the retina. It doesn't use any radiation, it just uses light, but it lets us see what's going on inside the back of the eye so we can figure out, is this dry macular degeneration, wet macular degeneration, and what do we need to do about it? So we think the progression, and when I say we think, obviously there's a lot of research and a lot of knowledge about macular degeneration, but it's still interesting. There's still a lot we don't know about it, and so we think we understand what the progression is, but there's still steps we don't really understand exactly why some people get macular degeneration and some people don't, why some people's progresses quickly, some people it changes very slowly. So there's still things that we're still trying to understand. But typically we see that you start with a normal back of the eye, and then over time, we start to see some early changes from macular degeneration, which are those yellow spots that we call drusen. And so that's the beginning of the dry type of macular degeneration. And then a lot of people will just sort of stay in this early to intermediate phase of macular degeneration where they're not having significant trouble, maybe a little bit of distortion, but able to function well. But then unfortunately, some patients then progress to what we call the later stages. And the later stages are divided into two different parts. There's late stage of the dry, which is when the retina gets very thin. And then there's the late stage of what we call the wet, where there's bleeding and leaking of fluid in the back of the eye. And those are sort of the two main causes that cause people to have significant vision trouble. So generally with the dry macular degeneration, it's going to be a slow process. You're not going to wake up one day and not be able to see out of the back of the eye. It's a slow process that happens over years. And the retina in the back part of the eye, that film, just gradually gets thinner and thinner over time, and then that makes it hard to see because the part of the film that gets really thin, it doesn't work as well, and so it's not able to send that information back to the brain. So this is like we've been seeing in those pictures. You can see there's these yellow spots, And that's what we call the drusen, which is very characteristic of the early part of dry macular degeneration. And then for some people, it progresses over time, and this is very characteristic of the thinning. So basically, there's a spot in the center part of the back of the eye, which just gets very thin, and there's very little retinal tissue there, so there's a gap in the vision. And so that's why patients with macular degeneration, sometimes if they look a little bit off to the side, or a little bit up or a little bit down, they can try to sort of get the image to fall on a part of the back of the eye that's working well. Just another picture of that thinning very characteristically that happens in the back part of the eye. So how do we treat dry macular degeneration? And I think this is the biggest frustration for all of us in the field and for patients as well, because there really is just not great treatment for dry macular degeneration yet. And unfortunately, that's the most common type. 85, 90% of patients are going to have dry macular degeneration, and we just don't have great treatments yet. What we do know is obviously not smoking, so that's a big modifiable risk factor. And then these vitamin supplementation. And I'm inherently a little skeptical sometimes of vitamin supplements just because they sometimes don't have great research behind them. But these particular vitamin supplements have fantastic research. Been really big studies done by the National Institutes of Health with tens of thousands of patients looking at it over time. And we know that these vitamins, that these specific combinations can slow the progression of dry macular degeneration. So if you have dry macular degeneration, it's definitely worth taking the vitamins, and there's really very little risk to it. And they come, there's tons of different brands, and really what we're just looking for is for it to just say this AREDS formulation, and that's how we know it has the right combination of vitamins in it. We also think that just sort of following a heart-healthy diet and not smoking are other things we can do to avoid the dry macular degeneration getting worse. But unfortunately, that's the state of the art right now, which is hard in 2021 to say that's the state of the art. But there's lots of clinical trials going on, and there's been a couple drugs, unfortunately, that have failed over the last few years, but there's a lot of interest in the scientific community to find better treatment. And we're lucky that we just started in the past 6 months participating in some of these clinical trials, and we're actually starting a clinical trial for the dry macular degeneration. It's going to be a medicine by mouth, and the hope is that medicine will stop the macular degeneration from getting worse. So there's lots of research and lots of clinical trials going on, and we hope to have better treatments for dry macular degeneration soon. But right now, it's sort of just prevention. And the big thing that we can do is we want to make sure that the dry macular degeneration doesn't turn into wet macular degeneration. If it does, we have fantastic treatments for wet macular degeneration, so that's why we want to know about it right away. And the best way to monitor that is we use this thing called an Amsler grid, and it's nothing magic about this particular grid. It's just a bunch of straight lines. So I have patients that will use their Venetian blinds or like their picket fence, anything that has sort of straight lines. And if these straight lines start appearing wavy or distorted, then that could be a sign that maybe the macular degeneration turned into wet, and then we would want to know about it right away. So again, just like an artist representation, but instead of the grid being nice and straight, you get these distortions in there, which can be a sign that it's progressing into the wet kind. So we talked a little bit just, for the dry macular degeneration, there's also low vision aids and specialists to try to sort of help restore some of that function. So future directions we talked about, there's a lot of drugs in clinical trials. There's a very big research interest right now in dry macular degeneration. Some of the state of the art or doing stem cell transplants or using different type of stem cells in the back of the eye, but it's still very early. And we have to be careful. Unfortunately, there's been some unregulated trials done in the US that have unfortunately caused a lot of harm to patients because they just weren't really following good research protocols, and people hear stem cell and it sounds high tech and state of the art, but so you always have to be a little careful before joining a clinical trial to really know who's running the trial, how reputable is it, has there been good preliminary research to know that these treatments are really safe to move into human testing. So that's something always to keep in mind. Okay, so wet macular degeneration. So different than the dry kind. So the dry, again, is that thinning that occurs in the back part of the eye, whereas the wet is actually abnormal blood vessels that start growing underneath the retina, so underneath that film in the back part of the eye, and then they start bleeding and leaking fluid, which is what causes the trouble in wet macular degeneration. So about 10% of patients with macular degeneration will convert into the wet kind. And once you have it in one eye, about 35% of patients will get it in both eyes. So it's not uncommon to have the wet kind in both eyes. And this is just a picture trying to demonstrate. So this over here is what a normal retina looks like. So it has these nice layers and this dip in the center. And then when we compare it over here, you can see the big difference that there's this big mountain right here, and there's this black space underneath. And this is where the abnormal blood vessels are growing and where it's bleeding and leaking. So the good news for the wet macular degeneration is that we actually have fantastic treatment for it that have really evolved over time. You know, probably about 15, 20 years ago, we used to do just a laser treatment, which was not much of a treatment. Essentially, we would have to burn the blood vessels in the back of the eye, which sometimes caused more damage than the actual blood vessels themselves. So thankfully, we don't do this anymore. Really, the way we treat this is with injections of medication inside the eye, and that medicine works on the blood vessels and gets them to stop leaking, and then it can prevent that damage from happening to the retina. And so these treatments are really fantastic with a 95% chance of maintaining the vision where it is, so keeping it from getting worse, and then really a good 30 to 40% chance of actually being able to improve that vision. And then another older treatment that we don't use as much is called PDT, but really the main state of the art is doing these injections. Sometimes we can do surgery if there's a really large bleed in the back of the eye. You can do surgery to try to remove that blood. But the mainstay of treatment is really those injections. And they've really worked fantastically for patients and saved just hundreds of thousands of people's vision. So, you know, whenever I tell people we're going to do injections in the eye, the first thing they think is that's crazy. You're not coming near my eye with a needle. But once we sort of move past that initial, it's actually, thankfully, it's basically virtually painless, a relatively low-risk procedure, and thankfully patients do really, really well with it. And once we sort of get through that initial, discussion of what we're going to do, it's very easy and works really well and is really just not that big of an impact. So there's a discussion of which of the medications are we going to start, because there's 3 or 4 medicines on the market, and so we'll talk about that with patients, the pluses and minuses of the different type of medicines. How often? Usually we start with the injections once a month. So that's the biggest burden to patients, is that we have to do these treatments once a month in the beginning. And then the hope is, as they start working for patients, we're able to spread that out and do it less frequently. But initially it's once a month. How long do they need the injections? And again, that's really hard to say. Some people only need a few of these treatments and then the blood vessels go away. Some people are on the treatments every month for years and years. And then there's just a lot of people in between. So it's really individualized how patients' eyes are how long they're gonna need the injections. And generally, generally the answer is no, because there's a lot of different ways that we can numb the eye, and for almost everybody, we're able to find a way to numb the eye that is just not that uncomfortable, thank goodness. So, even though there's great treatments for the wet macular degeneration, there still is a lot of room for improvement. And really, the biggest area for improvement, and where the research is for wet macular degeneration, is trying to do these injections less frequently, and trying to not have patients need them every month, but maybe every 2 months or every 3 months or 4 months. And so that's where a lot of the research is try to be able to do these treatments, keep them still equally effective, but do it less frequently. And from that end, there's a new device that was just recently FDA approved, and it's actually an implant that goes inside the eye, which serves as a reservoir for this medication. And so instead of getting the injections every month, some patients you could then just fill up this reservoir once or twice a year, and then it just slowly provides that medication. But there's a lot of subtleties, and it's not necessarily right for everybody, but that's sort of one of the new advances to try to make it less of a burden on patients. And then there's also gene therapy and stem cell transplants, a little farther in the future for the wet macular degeneration too. One of the really interesting ideas that's in trials right now is to actually, instead of injecting the drug inside patient's eye, to actually allow the eye to make the medication itself. And so that's what we call these gene therapies, that you can actually, through a very specific type of virus, is able to go inside the eye and then put that specific gene in the retina. And then instead of injecting the medicine every month, the back of the eye actually serves as its own little drug factory and makes that medication. And so that's that's a little more in the future and a little bit on the cutting edge. But again, one of the ideas to how do we make this more convenient for patients and not have to get injections every month, and how can we make it last longer? All right, well, that's a quick whirlwind through macular degeneration. I'm going to turn it over to Dr. Meyers in just a few minutes to talk about cataract surgery. Does anybody have any questions? And I'll definitely hang around at the end.
Thank you. Could you comment on posterior capsulotomy and how it plays in this discussion that you just given?
Yeah, so it's a great question. So the question was, how does doing a posterior capsulotomy play into macular degeneration? And so what that is so after you have cataract surgery, that new lens is put inside of a bag inside of the eye, and the back of that bag can get a little cloudy over time. And in terms of macular degeneration, just like doing cataract surgery, removing that scar tissue with a laser procedure is very beneficial to patients because it doesn't make the macular degeneration worse. And again, it serves, instead of allowing as much light as possible, to get to the back part of the eye. So again, just like I'm really sort of trying to encourage my patients to get cataract surgery, I encourage them to also get rid of that scar tissue just to let as much light get back to the retina as possible. You've got the microphone here.
Can you hear me?
Yeah.
Is detached retinal fluid a precursor to macular degeneration?
So the question was, is a detached retina or fluid under the retina a precursor to macular degeneration? And so it depends on the circumstance. So generally a retinal detachment, which is something, when the film in the camera falls off the back part of the eye, generally that's not related to macular degeneration. That's something completely separate, and we treat it separately. But part of the question was, can fluid underneath the retina be a precursor to macular degeneration? And in that case, yes, sometimes macular degeneration is one of the causes that can make fluid accumulate in the back of the eye. So if you are diagnosed with a retinal detachment, luckily through surgery, we're able to fix it about 99% of the time. So even though it's scary and something bad for the back of the eye, it's definitely something we can fix. Let's do one other quick question, and then we'll let Dr. Meyers go, and then I'll hang around at the end.
My companion has wet macular degeneration. He gets shots in his eye once a month. He worked on the equator for about 25 years. Is there any connection between being in a lot of sun and having this happen?
Yes, that's a great question. So the question was, is there a relationship between sun exposure over the course of your life and macular degeneration? The answer is a little bit that we don't know. We think some studies definitely suggest that there is an association between sun exposure and macular degeneration. But then some studies, don't suggest as much of a connection, and it's a really hard thing to measure. And to the point that actually about 5 or 10 years ago, A lot of the lenses for cataract surgery were actually tinted yellow to try to prevent UV light or that blue light from getting to the back of the eye, because we thought that was a big risk factor for macular degeneration. But actually recently we've steered away from those yellow lenses because I think we're realizing it's not as much of a risk factor as we thought, and sort of blocking that blue light can cause other trouble for people. So the answer is we think there probably is some risk with sun exposure, but we don't really know how big that is, and it's probably a much smaller risk factor than family history or smoking or things like that. So yeah, so generally just wearing sunglasses and, eye protection is good for, a lot of reasons. So great. I'm going to turn it over to Dr. Meyers, but I'll hang around at the end for as many questions as anybody has. You're all set.
Wonderful. Okay. It sounds like you can hear me now then. So I apologize. I've got a little bit of a frog in my throat. So that was an excellent presentation, Dr. Kanoff. Thank you very much. So we're going to talk now about some of the latest important things that are new and different in the realm of cataract surgery. I'm Dr. Joel Meyers, and I'm now the old doctor at the practice. So let's see if we can get this to advance. There we go. So as Dr. Kanoff showed before, we're at the Eye Care Center of Northern Colorado in Longmont, and the world of medicine is changing rapidly as we know it. We are a 100% Colorado and physician-owned practice, which is starting to become a rarity even here in Boulder County. Although we're the largest eye care providers in Boulder County, we're actually the little guy anymore in that Wall Street and big business has invaded the world of medicine, even in the world of eye care here in Boulder County. And so support the little guy. So in our practice, we currently have 5 retina specialists. Sadly, Dr. Benedict is going to be retiring here in another couple of months, but we have excellent retina specialists. I'd let any one of them take care of me or my family, and they have. My father has macular degeneration and has been cared for by the doctors in our practice. We also have 3 glaucoma specialists who all do cataract surgery. They're all superb. Dr. Werner is a cornea specialist who does cataract surgery, and I do the cosmetic and reconstructive eyelid and facial plastic surgery, as well as the cataract surgery. I've done over the last 34 years over 10,000 cataract operations, and my partners are coming up shortly behind me. Within our practice, we probably do, I'm guessing, over 3,000 cataract operations every year. And the reality is we're all going to get them, and I'll explain why in a little bit. We also have 3 doctors who do comprehensive eye care as well. So we're going to talk today about dropless cataract surgery, as well as what's old and what's new. And the objectives today are to, again, talk about studies that show about laser-assisted cataract surgery, the review of the state-of-the-art dropless cataract surgery, and describe the pros and cons of post-op drops, as well as new and different types of lenses. Now, as I said before, the reality is that we are all going to get cataracts, and we're all going to need cataract surgery someday. And that whole process where we start needing reading glasses in our 40s, that's actually the beginning of cataract formation, in that the lens inside the eye loses its elasticity. It's not able to change shape as quickly or as much as it used to. And so, by definition, anyone over the age of 50 has a cataract to some degree. The only question is how bad and how quickly do they progress. I hear patients all the time say, "Oh, I hope I never need cataract surgery." And my response to them is, I actually really hope that you do, because the only way you would avoid cataract surgery is by dying young, and I certainly don't want you to die young. And so that's just the nature of the beast. We're all going to get it. If I had the answer, or if you had the answer for stopping cataract prevention, we would be lending the money to people like Bill Gates, Warren Buffett, Jeff Bezos, Elon Musk, who didn't have enough money, and they would say, I got a cool project, I need $1 trillion, and we'd say, sure, I got lots of trillions, let me help you out. So it's just the reality, we're all going to need it someday. So one thing that's new in the realm of cataract surgery is, as it relates to laser-assisted cataract surgery. This came out about 10 years ago or so as the latest, greatest new slice and dice approach to cataract surgery, and we did it in our practice for some time. And the reality is, as studies have shown out of Europe, which is the proving ground for a lot of things that happen in the world of medicine, the FDA slows things down here, so Europe ends up being a guinea pig for a lot of things that happen here eventually. And the reality is that a very large study out of Europe showed that the outcomes of laser-assisted cataract surgery are not any different compared to conventional phacoemulsification surgery, which is the standard, and it's not cost-effective. And there are studies that have been shown in the journals here in the US as well that it doesn't confer any advantage. And so if you're being told that you need to have laser-assisted cataract surgery, the reality is it doesn't make a difference and you're wasting your money. So back 25 years ago when I was doing, well, I was still doing a lot of eyelid tucks, the laser came out as an option to help improve the technique for eyelid surgery. We were, for a brief time, using lasers to make the incisions. And the reality is it was shown over time, it doesn't make any difference. It just increases the cost, slows you down, and actually increases certain risks. And that's the same here. So in our practice, we were on selected patients. We did use laser-assisted cataract surgery for about 8 years, and we stopped doing about 2.5 years ago. We don't want to waste your money. And we live by the golden rule. We don't talk people into things. We let them know what their options are, and we help guide people as far as making decisions that make the most sense for them. So that's where things are in the world of laser-assisted cataract surgery now. So let's talk about ocular medications in cataract surgery. And the goals of medications after cataract surgery are to help prevent infection. Like any surgery, there's that theoretic risk of infection, and as well as to treat inflammation and swelling. Anyone who's had surgery knows that you make a cut anywhere in the human body, there's going to be some swelling, there's going to be some inflammation, and the goal is to make that go away. We don't like to see that happen. And obviously, no one wants an infection inside their eye. And so in the realm of cataract surgery, there's a lot of different eye drops that are used. There's antibiotic eye drops that are used. There are steroids, which help diminish inflammation and swelling. There are non-steroidal anti-inflammatories, the Motrin-type drops that do the same thing. There are lubricants, because oftentimes after cataract surgery, the eye feels irritated. It's scratchy, stingy, and those are normal things, but patients oftentimes need to use lubricating drops. And the reality is there's not a single perfect answer to any of this. So the question is, why consider doing, avoiding drops altogether if possible? Well, there's a lot of different drops that people can potentially need to use. And we're always trying to make things simpler, using the best medicine possible though. And so this here is showing an example in its worst form of what drops might be after cataract surgery. There was a time when we were using eye drops before surgery, and we're not doing that any longer, but we're having patients use drops 4 times a day, 2 different flavors, an antibiotic and a Motrin-type medication. And then after cataract surgery, in its worst form, we were having patients use 3 different kinds of eye drops, 4 times a day for the first week, 3 times a day for the second week, twice a day for the third, and once a day for the last. And it can become very onerous. It can take a lot of time and effort. And so again, first 10 days, it added up to 110 drops. And then over the next 2 to 4 weeks, it was another 126 drops for a total of 236 drops. Again, that was in its worst form. There were other regimens that were simpler, but based on insurance and the needs of the individual, that was what was used for quite a number of patients. So, when it comes to antibiotics, we still want to use antibiotics to help prevent infection. Commonly used medications that were used for cataract surgery included these here, and there was an excellent study that was done out of India a number of years ago, and in India they have like cataract camps and cataract hospitals where they do huge quantities of cataract surgery. And so this is from an excellent study that was out of India, looking at 116,000 patients, and they used a medication called moxifloxacin that was squirted inside the eye at the end of surgery. And doing that, there was a 4-fold reduction in the risk of infection. And so without that antibiotic, the risk of infection was about 1 in 1,000, a little less than that, 7 in 10,000, down to 2 in 10,000. So it definitely made a difference. Fortunately, the risk of cataract surgery is very small, but we're always looking to minimize those risks. And the reality is that the single most important thing to help minimize an infection inside the eye after cataract surgery is the nurse doing a thorough prep before surgery where they clean the eye, the surface of the eye with a betadine medication, betadine prep, and that makes a huge difference. In addition, before we do anything, we always instill within the eye 2 or 3 drops of betadine, and that's done several minutes before we even begin. So this is actually the most important part. So infection prevention is one of the components. The other thing is steroids. And we use steroids to, again, remove inflation from inside the eye that occurs, reduce pain, speed the visual recovery, and these are 4 of the common medications that have been used, and it is a very important key to the equation. If there's significant inflammation or swelling that occurs, that can actually work its way back to the retina, and then the retina specialists like Dr. Kanoff in our group have to help assist in diminishing that. So we really do want to take away swelling and inflammation. So in addition to the steroids, there are the non-steroidal medications, again, the Motrin type medications. And additionally, these, like the steroids, help reduce inflammation, reduce pain, speed the visual recovery, and these are some of the drops that were used commonly for that. So, and then in addition, a lot of patients, because of irritation, all the drops, they were needing lubrication to help minimize the pain and irritation. And you know, when you're using so many eye drops, the eye starts getting irritated just from the preservatives in the drops, and so drops, lubricating drops that don't have preservatives are a better option. So, so the advantages of the dropless approach are you're not having all that energy expended into trying to put the drops in, remember to put the drops in, trying to make sure that you're using the right drops, that sort of thing. Cost, currently there are insurance companies that will cooperate with the approach of using the dropless approach that we have, where they will pay for it. Now, the sad thing is that these medications that are used are extremely expensive. They can be over $1,100, you know, additional cost through insurance for the purpose of achieving this. And that's like double what the surgeon gets for the surgery. So Big Pharma makes out big time on that. So cost is a plus minus there where, again, insurance may cover it. If it doesn't cover it, we certainly wouldn't recommend someone pay out of pocket. So there's the cost. There are fewer topical side effects when you're not using all those different drops. And we get less calls to the office about questions about the drops because people aren't having to fool with it. So there are some definite advantages there. Patients do tend to like the concept. Now, again, we talked about the typical, the worst case scenario for drops with all these 236 drops here. Again, there's hundreds of drops, multiple chances for missed or wrong drops. Antibiotic resistance isn't really that big of a concern. So there were some cons there. Now, the disadvantages are the cost. I hate creating extra costs in the healthcare system for anybody, and over time it's something that we do need to be conscious of. The anatomy, there are some situations where we can't use some of these medications, and I can explain that more perhaps later. There are temporary effects on vision. Sometimes people can be aware of a floater and be concerned about that. We all get floaters. That's another one of Dr. Kanoff's specialties. And the concept of breakthrough pain or inflammation requiring drops to use in addition. So our experience has been that utilizing this dropless approach, about 1 out of 10 patients still needs to use drops no matter what. When we see patients a week after surgery, we're looking at all the details, and if we see that there's still more inflammation than we'd like to see, more swelling than what we'd like to see, we have to start using the medicated drops no matter what. One of the other things that we have become aware of is that when you're using all those eye drops after surgery, when you're using that approach, using eye drops, you're putting wet stuff on the surface of your eye. And with the dropless approach, we have patients fairly often commenting that, boy, you know, my eye feels irritated. Is there something wrong? Well, we're not putting that wet stuff, no matter what it was, on the surface of the eye. So a lot of patients are needing to use lubricating drops no matter what. So the dropless doesn't necessarily mean that it's going to be dropless, because you might need to use lubricating drops, and again, about 1 out of 10 patients or so still needs to use medicated eye drops. And one other disadvantage is that because of the steroid that we're putting inside the eye, there is a potential for someone to have a reaction to that. Not common, but possible. So the current dropless regimen that we're using in our office for those selected patients is to use the moxifloxacin that has been well shown to help minimize the risk of infection, and that's placed inside the eye at the end of the operation. Also, throughout the procedure, we're running a fluid through the medication that's a Motrin-type medication that helps minimize the inflammation throughout the process of the surgery itself. And then at the end of the operation, currently we're squirting inside the eye this little pearl. You can see a little picture of it here inside someone's eye. This little pearl of a steroid medication that releases the steroid into the fluid inside the eye over the 3 weeks or so after cataract surgery, helping minimize that inflammation and swelling that occurs. So it's a nice option for patients, that combination. Now, again, in summary, with regard to the dropless approach, there is that significant expense, and we would never remotely recommend someone pay out of pocket for it, because there are excellent options that can work very nicely. So in our practice, we're not using the antibiotic drops afterwards. There are some patients, as I said, about 1 out of 10, who will still need the medicated eye drops. And without medicated eye drops, many patients still need to use lubricating drops for comfort. So over time, I think that we're going to probably be looking at a hybrid of this, in that we are definitely strongly in favor of the use of the moxifloxacin antibiotic squirted inside the eye at the end of the operation to help minimize the risk of infection. But because of costs and some other subtle nuances, it's really not for everybody. And over time, it might be that we simply go to the hybrid where we have patients use eye drops, and it can be very simple, anywhere from 2 to 4 times a day, not that 236 approach. So that would certainly make things simple, give the best of both worlds without creating exorbitant costs through the world of medicine for increased medications and the cost of those medications to Big Pharma. In case you haven't noticed, I'm not real excited about Big Pharma. They provide wonderful medications in the realm of treating macular degeneration and things, but sometimes they get a little overboard. So at the end, I'll be happy to take questions on any of these things. Right now, I want to move on to lens implants. So as Dr. Kanoff was showing in cataract surgery and the diagrams he showed on the eye, the lens inside the eye is becoming cloudy. That's all a cataract is. And during the cataract surgery, we place an artificial lens inside the eye. And the question is, what kind are we going to use? And it was a lot simpler about 20 years ago when it was like Henry Ford and the Model T. Any color you want as long as it's black. Nowadays we've got choices. It used to be there was a single type of implant, and that was it. So nowadays we have choices. And there are implants that diminish astigmatism, and I'll explain that more in a moment. There are bifocal implants, trifocal implants, implants that are progressive, like those of you who have glasses that bring your focus from far away up to actually an intermediate distance, not up close, unfortunately. There are implants that try to claim that they're going to be accommodative. The accommodation is that process that we have when we're younger, where we can see far away and have that zoom focus that lets us see up close. That would be the ideal world. There's an implant that claims to do that, but it doesn't really work, to be honest. And then there's what's called a light adjustable lens, which can fine-tune things perhaps more precisely. So the question is, what's best for any given individual? And so let's talk about lens implant materials. Back when I first started doing these cataract operations in 1986, the implants were made out of polymethyl methacrylate, which is a hard plastic. It required a large incision to go through, and it wasn't foldable, flexible like the implants are nowadays. Nowadays, the implants are foldable. They go in through a small incision that's about 2.4 millimeters in width, and they're fantastic. The standard implant material nowadays is acrylic. There are silicone implants available. The acrylic is really preferred. The problem is silicone implants can cause extreme difficulties for retina surgeons like Dr. Kanoff if they're doing certain types of retinal detachment repairs. We have a gentleman's rule agreement in our practice: thou shalt not put in a silicone implant. It can really create challenges unnecessarily for the retina surgeons. And one of the challenges there are that the crystal lens and the light adjustable lens are silicone implants. So those are two reasons why we don't use those in our practice. For selected patients, if the technology improves, we might consider a light adjustable lens. But again, we'll talk about that more in a moment. So let's talk about lens implants and diseases for a moment. Patients who have glaucoma or retinal diseases such as macular degeneration are not a candidate for the bifocal or trifocal implant. And the reason for it is that those implants decrease contrast. Now, an example of contrast is, if I was trying to figure it out before, but I couldn't, if I could lower the lights in this room, you would see the pictures and writing on the screen better because you have better contrast. If I were to make the light in the room brighter, you can't see, it's even worse because there's less contrast. So the problem is that people with macular degeneration and glaucoma need as much contrast as possible. And it would be a really bad idea to use one of these types of implants in someone with either of those diseases. So as cataract surgeons, when we're chatting with patients about their options, we're looking for those issues that they might have that would pre-select them for not being candidates, ruling them out potentially of different types of implants. So let's talk for a moment about focus points. We all have a desire to see as well as possible. Most of us aren't blessed with perfect vision, and in the best of all worlds, you can see far away, intermediate, and up close all at once. And that's what young eyes that don't have nearsightedness or farsightedness or astigmatism are able to get away with. So that would be the best of all worlds. For cataract surgery, patients tell us what their goals are. Someone who loves to read all day long, that's their passion. Maybe they want to be focused so they can read their books or their Kindle without glasses. That's an option. Some people, most people say, yeah, let me see far away. And there's other people who their most fervent goal is to be less dependent on glasses. For those patients, a bifocal or trifocal implant or a progressive type implant might be a great option. There are patients who were born with one eye for distance, one eye for up close. They're used to that. That's called monovision. They might want that. Some people do that with contact lenses. It's an excellent option if your eye is used to it. If your visual system isn't used to it, it's not a good idea to suddenly put someone in that position. So, Dr. Kanoff showed a similar slide earlier. We're going to talk briefly about astigmatism because there's always questions that come up about that. So at the front of the eye, we have the clear part, the cornea, where people would put a contact lens. And all astigmatism is that cornea, the round part at the front, the clear part. In an ideal world, it's round like a basketball. However, with astigmatism, all it is that instead of being round like a basketball, it's got two curvatures like a football, a tight curve from point to point. Sorry, a tight curve where you would grab it, and a gentle curve from point to point. That surface has significant astigmatism. And the astigmatism can be at any orientation along the clock hour. And so there are implants that help diminish astigmatism. They're fantastic. I have a fair amount of astigmatism. I'd have that lens in my eye in a heartbeat. It's an excellent option. And there's different companies. The Alcon implant's the most stable. And it's also available for patients who are interested in the trifocal, bifocal, or progressive implants. So the toric implant, this is an example of one, and you can't see the curvature, that football curvature, because this is extreme, and it's into the shape of the lens. These little three dots on each side show us where the orientation of the football is, so that we mark that orientation before surgery, and we line it up with the implant, rotating it at the correct orientation for that individual. And the reality is that the steep curvature is actually along the orientation where the dots are. So this is the orientation that goes. So bifocal and trifocal implants, they work by having these concentric rings in them, which hopefully because of the contrast in the room you can see, but they have these rings, and they have rings for distance, near, intermediate to help with that focusing. And this shows a more close-up of those rings. And the challenge is that, well, let's back up. It's a reasonable option for someone who wants to be less dependent on glasses, and that's their real fervent goal. The cons with them are that those rings can cause halos around lights. If you're someone who drives at night a fair bit, you would probably hate it. If you're someone who doesn't do significant night driving and you're willing to put up with a little bit of extra halos, it might be a reasonable option. My experience is that engineers hate it. They're just too detail-oriented. Architects as well. And also, as I mentioned before, it's not a good option for patients who have retinal or glaucoma diseases. Now, the progressive implants, they provide for focusing from distance up to about arm's length. You still need to wear bifocals for up close. It is an excellent option for someone, and it can be considered as an option for someone with glaucoma or retinal diseases, because it doesn't have the halo issues like the bifocal and trifocal implants. And so you can see here this shows, and it doesn't have the rings like the other ones did. And the accommodative implants, they've been out since 2002. I went to one of the very first presentations on these kinds of implants, and I walked out of there thinking I just wasted a whole lot of money and energy going to a course for an implant that I would never use. And the implants have this little hinge here which allows the implant to theoretically bend and change position inside the eye slightly. And the reality is the movement is almost non-existent, and it doesn't really provide what it claims to. It's basically the emperor's new clothes. It overpromises and underdelivers in a major way. It's a silicone implant, not a good option for patients with retinal issues. And we don't do that in our office. Again, we live by the golden rule. And now there's a light adjustable lens, which allows the prescription to be changed after cataract surgery. For someone who's had laser vision correction, radial keratotomy, it might be a better option. We're always striving to get patients exactly where they want to be. If someone says we want to see far away, we want to get them far away. The measurements we do are insanely precise. The calculations aren't as good for patients who have had refractive surgery, LASIK, or radial keratotomy. So this would be a theoretically better option for someone who has had those treatments. In general, with the current technology, we do an excellent job, but this implant doesn't have the bugs worked out of it completely yet. In order to adjust the implant after surgery, it requires 3 to 5 adjustments, and so it requires 3 to 5 adjustments after the procedure. The patients in the meantime have to wear glasses that block out all ultraviolet, because the ultraviolet treatment after the surgery helps lock it in place, and we don't want to lock it in too early. And it's a silicone implant, so not a great option for certain retina patients. So this one, it's still in the proving stages, and we always in our practice want to be able to offer the best technology that's proven. And this one, the jury's still out on it a fair bit. So that's covered a lot of ground. I'm happy to answer questions here from the group, as well as Dr. Kanoff for his portion of the presentation. Yes? That's an excellent question. The question is, does cataract surgery ever need to be repeated down the road? And the answer is no, one and done. However, as was commented on earlier with another question, statistically, over half the patients who have cataract surgery will someday develop some haze behind the implant on the membrane that holds it. And if that happens to a large enough degree, then there's a simple laser treatment we do to make a window, and that clears up the cloudiness.
So one question would be, why wouldn't, if you wanted to improve your vision, why wouldn't you get cataract surgery early instead of waiting to your 70s or 80s? Why wouldn't you get it in your 60s so it corrects your vision as much as possible?
Excellent question. So if anyone couldn't hear, the question is, why not consider doing cataract surgery earlier rather than later to take advantage? And in general, if it doesn't bother you, it doesn't bother us. You never do surgery willy-nilly, because just about the time you do something just for the heck of it, that's just about the time that Murphy jumps up and bites someone in the backside with an unlikely problem. But we don't like to see cataracts become really advanced. All that does is increase the risks unnecessarily. So we'd rather do surgery when they're moderate and not severe. And by doing it sooner, you certainly take advantage of seeing better sooner. But it's all based on your quality of life. If you're able to do the things you want and need to do, you leave it alone.
Yeah. Unfortunately, because we're running a little long and we've got another session starting, I'm going to suggest that anybody has specific questions for the doctors, if you could, talk to them out in the hallway or at the booth, either one. Because I know this one has a high level of interest, because all of us are going to develop what Dr. Meyers talked about today. So let's give them all a round of applause. Thank them so much for their time and their information.